module number 16, which is on ICU device infections and infection control. And thank you so much for joining in large numbers in all the modules so far. And already I can see a lot of people are already there. Today it will be moderated by Dr. Deepak Govil. Before that, as you know, that we recapped the last session, which was on infections in transplant and non-transplant immunocompromised patients. So I'll request Dr. Akanksha Chawla to start the recap, and she's working as a senior consultant in the Department of Respiratory and Critical Care Medicine at the Hospital.
Thank you, sir. Good evening, everyone. So I'm going to be recapping module 15, which was on infections of the immunocompromised host, and we are going to look at lung infections in transplant and non-transplant patients. I hope my slides are visible.
Yes.
So the objective of the last lectures were to be able to understand and classify an immunocompromised host and not generalize the term immunocompromised pneumonia. Recognize what phase post-transplant the patient is in, how the rejection therapy or graft versus host disease resets the risk. Understanding the HRCT patterns to narrow down the possibility of infections and how to correlate them clinically. Know when to do a bronchoscopy and BAL, and specific indications for biopsy. Simplify non-transplant immunosuppression, especially with steroids, biologics, patients with diabetics or lymphopenia. And then what to review at 48 to 72 hours to stop from your empirical cover, narrow down the therapy based on specific tests, what to continue, and when to biopsy. So a simple framework basically involves, to understand what phase of the immunosuppression the patient is in, what post-transplant day chemotherapy phase, has the patient received any pulse steroid, how many days post-pulse steroid, any recent biological exposure. Then to understand the defects, whether there is the absolute neutrophil count is, what is the level, the T cell, B cell, if there is any barrier which has been compromised, any device which is infected, or any metabolic or organ dysfunction present. Then what is the CT pattern showing you? Whether there is presence of ground glass opacities, nodules, halo, trine bud, cavitation, consolidation, any associated CNS or skin lesions. For example, a patient post-renal transplant at day 45 with T cell suppression and diffuse ground glassing on the CT. So, you have to keep in mind the possibility of pneumocystis jirovecii, CMV infection, viral, as well as diffuse alveolar hemorrhage. Unless you keep this in mind, your empirical cover will lack the initial therapy of choice, and delaying in immunocompromised hosts, can lead to catastrophic events. So, initial bedside triage would obviously involve first assessing the patient clinically, knowing whether the patient is stable or sick. Is he in septic shock? Is he hypoxemic? Is there presence of neutropenic sepsis, altered sensorium? Any of these present only tells you that the patient is unstable, he is critically ill and requires immediate treatment. Then what is the immune defect that you're dealing with? How is the absolute neutrophil count, the lymphocytic count, CD4 level, history of any history of any steroids or any biologics or transplant drugs that the patient has been on, these HRCT pattern, and based on your clinical presentation, patient's severity, and the site of involvement, you decide about the samples that you want to send, which could be the blood, sputum, bronchoalveolar lavage, biopsy, CSF sample, and even tissue sample from skin, adrenal, or lymph nodes. The immune defect can also predict the possibility of organisms or what to prioritize. For example, if your absolute neutrophil count is less than 500, or patient has a recent history of chemotherapy or myelodysplastic syndrome, you need to prioritize gram-negative bacteria, including Pseudomonas, Candida, Aspergillus, as well as Mucor. Patient with T cell defect and with recent history of steroids, graft versus host disease, or low CD4, you have to prioritize covering for pneumocystis cerevisiae, cytomegalovirus, varicella zoster, cryptococcus nocardia, tuberculosis, as well as NTM. Then B cell or splenic defect with history of any rituximab, CLL, or myeloma. So encapsulated bacteria and severe viral infections should be kept in mind. Any barrier compromise, patient may have mucositis, an infected central line. So we all understand that gram-negative bacteria is something which is very prevalent in our ICUs as well. So you need to remember even in this case that gram microbial infection. Then patients with an underlying disease in the liver or the kidney or diabetics or who presents in diabetic ketoacidosis, so mucor, nocardia, again pneumocystis, TB and endemic fungi need to be prioritized. So the defect can guide you to understand the possibility of organisms and prioritize your therapy accordingly. Then, what do you do when you see a pulmonary infiltrate in an immunocompromised host, and how should your plan be in the first 72 hours? So, in the first 1 hour, naturally, the first and the foremost thing is to stabilize your patient. If your patient is sick, the priority is first to stabilize, then send the appropriate cultures and samples, and start the appropriate empiric therapy. Do the HRCT on day one and non-invasive panel. You can send secretions, do a mini BAL, send ET aspirates, and BAL should be done early within the first 24 to 48 hours. If your CT is showing you ground glass nodules, ground glass opacities, nodules, and if your initial therapy is showing you no response in the first 24 to 48 hours, then once you have your appropriate cultures at 72 hours, you have your PCR tests and your biomarkers, you correlate it, you see what you want to de-escalate, narrow down. And in certain instances where you still don't have a response, or your empiric therapy, the patient is not getting better at all, or there is no diagnosis yet, you may need to also do a biopsy. So remember that BAL is safer in a stable patient than after intubation. So you must plan sampling early. Then, transplant risk is a moving clock. Solid organ transplant patients have different set of infections as the time period since transplant passes. So you must remember to ask the day from transplant and recent rejection or graft versus host disease treatment before choosing your empiric therapy. So, in solid organ transplant in the first month, common syndromes that you would often come across would be hospital acquired pneumonia, ventilator associated pneumonia, aspiration, line induced sepsis, surgical site infections, even urinary sepsis. It can also be donor derived infection. There's always a risk of MDR, and that would also depend upon for how long your patient has been hospitalized, number of hospitalizations, recent or prior use of any antibiotics. So all of that would add up to the MDR risk. And of course, if there is any procedural complication or risk which is associated, any drain collections, any infected lines, or an anastomotic leak which has been present, would require an early evaluation in the first month post solid organ transplant. Then in the subsequent 1 to 6 months, more of opportunistic infections, like infections with cytomegalovirus, pneumocystis cerevisiae, aspergillus, mold, nocardia, TB, and cryptococcus are more common. Then after 6 months, it is again the community-acquired infections that return. So you would want to cover for community-acquired pneumonia, if there's an influenza or risk of respiratory syncytial virus, COVID infection, depending upon the presentation of the patient. And you need to reset the clock when there is patient has a history of rejection therapy, pulse steroid use, lymphocyte depleting therapy, or a persistent CMV infection or a graft dysfunction occurs. After the solid organ transplant, the next set of patients that we often see is the hematopoietic stem cell transplant patients. And these are very different from the solid organ transplant. So pre-engraftment patient can have neutropenic fever, gram-negative bacterial infections, infections with viridins, streptococci, candida, HSV, early mold, mucositis, which can drive the bloodstream infection. Between 30 to 100 days, again, more of opportunistic CMV, PJP, aspergillus. respiratory viruses, and even idiopathic pneumonia syndrome. Late graft versus host disease would have more of infections with encapsulated bacteria, varicella zoster, mold, recurrent cytopulmonary infections as well. So it's the timeline post transplant, that you need to understand and accordingly, think of the possibility of infections in that phase and appropriately cover for your patient. Then there's a thing called the net state of immunosuppression. What is the net effect of the immunosuppression, which would include drugs that the patient has been on, any induction therapy, patient on immunosuppressives, tacrolimus MMF, any pulse steroid use, any ATG use, how is the counts, how is the absolute neutrophil count, which could suggest a count less than 500 could pose at a higher risk of bacterial or mold infection. Then an absolute lymphocyte or CD4 count low would suggest more of opportunistic pneumocystis, CMV, and even viral or fungal risk. Graft versus host disease or rejection therapy, the risk may be higher than the transplant date. And prophylaxis reality, this is very important to understand that you've given prophylaxis, but you need to know the correct dose that you've put, the adherence, whether the patient is actually following or not, and is there any factor which is hindering the absorption of the drug, or any uh, drug interaction, or any other drug that the patient is on which could prevent the prophylactic drug or specific prophylaxis that you've started, which could prevent its appropriate absorption. So all of this needs to be kept in mind, and the net state of immunosuppression should be kept in mind. One of the most important investigations after understanding the basic presentation, the defect, is the HRCT tests that we do for these patients. And the common patterns that we see on CT chest, beginning with diffuse ground glass, which is seen in pneumocystis cerevisiae, CMV, respiratory virus, even in diffuse alveolar hemorrhage or even drug pneumonitis. So as you can see, these axial and coronal sections, these are from the patient with PCP, and you can see there is very diffuse ground glassing across bilateral lung fields. Then another patient who had ground glassing, and this is a recent case who was positive for cytomegalovirus infection and came positive and was treated for the same, a post-renal transplant patient. Then there can be nodules in halo. So nodules in halo, as you can see around these nodules, there is a presence of halo. So which is commonly seen in patients with angioinvasive aspergillus, mucor, as well as nocardia. And this was a case, as you can see in these cuts, that there is presence of, again, big nodules. And this was a case of nocardia. Then the next pattern that we would see would be tree in bud. Now, tree in bud, usually as a pulmonologist, I would always think of tuberculosis as one of the first differentials. But of course, it is also present in other conditions, like it could be there in NTM infection, viral bronchiolitis, aspiration, as well as bacterial bronchiolitis. As you can see, both these CT cuts are showing you tree in bud pattern. Then, of course, we have cavitation, which can be seen in TB, nocardia, aspergillus. Remember, cavitation can also be seen in staph and klebsiella, as well as endemic fungi. And then lobar consolidation, which is, of course, in bacterial cap and HAP, but even in Legionella. We recently had a case who had a very specific right lower lobe consolidation. Again, a post-renal transplant patient. So once you have, identified your patient, you've understood what phase. Now, when you're investigating these patients on day one, your investigations should include a complete bundle, which should have tests for, of course, you have to see the phase of illness that the patient is in, what is the defect you're dealing with, what are the possible infections that you could be dealing with. But the overall investigation list in the initial day one should include bacterial investigations, in which case you should send at least 2 blood culture sets. Sputum, if you are sending, then gram and aerobic culture, MRSA screen and urinary antigens where they are relevant. Fungal, you send serum galactomannan as well as the beta D glucan level. Cryptococcal antigen, endemic fungi, and specific test for fungi where the exposure fits. Then for viral, CMV, quantitative PCR, even respiratory multiplex PCR can be sent, and EBV PCR when there's a PTLD risk. For tuberculosis, we all understand we always send the AFB smear culture and gene expert, and you need to do HRCT chest. Apart from that, if the patient is neutropenic, you may also need a sinus CT. So it should cover, so your test should cover for bacterial, fungal, viral, as well as tuberculosis. In our country, you cannot, rule out tuberculosis. Then bronchoscopy and BAL. Since we are talking about investigations, when does an early BAL help? When you have a patient with diffuse ground glassing, or patient has nodules, halo or reverse halo, when you're suspecting a mold disease, profound immunosuppression, absolute neutrophil count of less than 500, non-resolving infiltrates after the initial appropriate empiric cover for 48 hours, or atypical features like patient has a cavitation, effusion or lymphadenopathy. What do you send once you take your bowel sample? You send gram stain, aerobic quantitative culture, fungal stain culture, TB, AFB stain culture, and gene expert. For PCP, you do the DFAT as well as the PCR. For CMV, you again send the PCR, and you may even send the respiratory panel if needed. Then for others, for nocardia, modified Zn stain, Legionella PCR, cytology if you're suspecting any other non-infectious cause. Then next generation sequencing if still there is unresolved and you're not getting an answer with the appropriate microbiology that you've sent. So like I told earlier as well, BAL is easier and safer before intubation, and do not send a small incomplete sample when one full sample can answer multiple questions.
How's headache?
Apart from that, like I said, cytology can also give you clues, especially when it's a non-infectious cause like diffuse alveolar hemorrhage, which is diagnostic. When you're doing a BAL, malignancy, a PTLD, eosinophilia, or even drug toxicity. So you must know what to send once you've taken a BAL sample. Now, after the investigations and CT, and you need to start your patient on empiric therapy. And the empiric therapy again should cover at least these four groups. Bacterial should have an anti-pseudomonal beta-lactam plus an MRSA based on severity, colonization, and of course what the local data suggests. For mold, if you're suspecting aspergillus, then voriconazole or isovoconazole remain the drug of choice. Liposomal amphotericin B for mucor. For pneumocystis cerevisiae, you cover with trimethoprim, sulfamethoxazole, 15 to 20 milligrams of the trimethoprim component. And if the patient is hypoxemic, you need to cover with steroid. You need to add steroids as well. For viral, in case of CMV disease, ganciclovir, and of course, depending upon the specific viral that you're suspecting, antivirals could be started in the empiric cover. Now you do start a broad empiric cover where you're covering for bacterial, fungal, viral, and even specific viruses. So after that, you need to know based on what you are after you what to stop once you have an appropriate diagnosis, or if the clinical syndrome explains, or narrow down once you have your PCR and culture tests which support a specific pathogen directed therapy. You can continue for pneumocystis cerevisiae, CMV, aspergillus, nocardia, TB, or mucor with a defined plan. You cannot just endlessly keep giving. And biopsy when you do not have a clear diagnosis. So you need to review at 48 to 72 hours and not continue such a broad cover endlessly. So we've understood the basics of how to identify, what to investigate, what to interpret out of that investigation, what to start with an empiric cover, and how to narrow down or de-escalate. Now let us understand this with a case. This was a post-renal transplant patient on day 45, presented with tricarb hypoxemia and diffuse ground glassing on his CT chest. Now look at the timing. The timing is giving you a clue that the patient is presented in 1 to 6 months post-transplant. So he's come to you in a opportunistic infection window. Immunological clue. Patient was a post-transplant, was on triple immunosuppression with TAC, MMF and steroid. You need to check his absolute lymphocyte count and whether he was actually started on PCV prophylaxis or not. Now patient has cough, has diffuse ground glassing, is hypoxemic. So you need to keep the possibility of pneumocystis cerevisiae, CMV, viral, and possibility of DAH as well. But remember, if the patient is hypoxemic, start trimethoprim sulfamethoxazole while you're sending your bile for PCP as well as CMV. I'm sorry. Sorry. Now, what is the difference in the presentation of a patient with pneumocystis in a HIV as well as a non-HIV or a transplant? An HIV retroviral positive patient would have a subacute presentation over weeks, whereas a non-HIV would have abrupt over days. An organism burden would be higher in a retroviral but lower in a transplant or non-retroviral patient. Now, understand this that a post retroviral patient would have often a severe acute course, would be very hypoxemic, admitted in your ICU. And the mortality risk is also very higher with these patients because they are quite sick on the initial presentation. And diagnosis for the non-HIV transplant patients depends upon naturally the same way. You send the PCR, beta D glucon, and you do an early BAL for the non-HIV and transplant PGP patients. Sorry. So, based, how do you diagnose and then treat these patients? So, a possible PGP infection is when you have a compatible host, you have diffuse ground glassing on your CT, patient is hypoxemic, and the tests are pending. Probable is a patient with compatible syndrome. Your BAL, PCR, or the DFA or has a high beta D glucon without a alternative or any other diagnosis which is possible. And definitive is when the organism is shown by the direct fluorescence or the GMS staining or histology. So then you correlate it with the syndrome correctly. And the treatment is again trimethoprim sulfamethoxazole, like I just said, 15 to 20 mg per kg per day based on the trimethoprim component for 21 days. Patient hypoxemic, do not forget to add steroids, and you need to monitor the patient's blood glucose levels as well as monitor for co-infections. And after the cure, you restart or continue secondary prophylaxis until the risk falls. Another case of an allogenic hepatopoietic stem cell transplant, day 38, with graft versus host disease and ground glassing on the CT. Now, understand that this patient has come between day 30 and 100. So, again, opportunistic infections, respiratory viruses, and idiopathic pneumonia syndrome. Now, the defect patient is on prednisolone and tacrolimus for GVHD, so profound T cell suppression, and has diffuse GGOs without halo. So again, possibility of pneumocystis, CMV, as well as viruses should be kept, and you must screen for aspergillus as well. Send your blood CMV PCR, send your BAL samples, and start IV ganciclovir if the syndrome and the viral burden fit for CMV infection. Now this patient had CMV infection. So once you have identified your patients, understood the defect, started empiric therapy, done appropriate investigations, de-escalated based on the diagnosis, done biopsy in cases that is needed, there are certain specific diseases that we see quite commonly, like CMV pneumonitis, wherein the risk is seen in patients with allogenic HSCT, graft versus host disease, lymphopenia, steroid burden. Diagnosis is obviously based on a compatible syndrome imaging, and you send your blood and BAL CMV PCR. Tissue very rarely, but some certain cases you may need when the diagnosis is uncertain, and you start IV ganciclovir early in the severe disease. Then the other disease that we see in these patients is the invasive aspergillosis, and the high risk hosts for invasive aspergillosis are patients with prolonged neutropenia, post HSCT, GVHD, patients on steroids, lung transplant, prior CMV infection. CT, like I'd shown you earlier as well, you would see nodules, there would be halo around the nodules, there could be cavitation as well, and wedge infarcts. And the test that you send for aspergillosis would be your galactomannan in the BAL, which is often useful, then the serum, especially in cases of lung disease. And therapy, voriconazole or isavuconazole usually is the first line therapy for invasive aspergillosis. If there is a possibility or you're suspecting that there could be mucor, then you must consider therapy with liposomal amphotericin B. For mucormycosis patients, we've seen post-COVID also a lot of diabetics are specifically very prone. Then patients who can present in with deep, diabetic ketoacidosis, iron overload, renal failure patients, patients on a long-standing steroid exposure, and they may even have the evidence of tissue necrosis. So CT would show you a reverse halo in this case. There could be cavitation. You might even see pleural and chest wall invasion or the classical rhino or vital disease. And initial therapy is with liposomal amphotericin B. And if the patient has DKA, then you need to correct the DKA obviously and reduce immunosuppression for the time being if possible. Remember something very important about mucormycosis. If you don't do urgent surgical debridement along with the antifungal, you will not be able to salvage your patient. The patient always in mucormycosis. If the surgery is possible, the site is such that you can operate upon the patient, you need to get your surgeon on board and you need to operate the patient. Otherwise, it is very difficult. I mean, it's nearly impossible to save these patients. And do not rely on voriconazole if you're suspecting mucor. Now, another infection is nocardia, which is chronic, invasive, and multifocal. Mostly patients who've been on long-standing steroids, diabetics, or some with cell-mediated immune defects. You would have a subacute pulmonary disease sort of a presentation. Patient would have nodules and cavitation, may also have adrenal lesions. You send a modified ZN stain for nocardia, and you need to talk to your microbiology lab why you're suspecting nocardia. And treatment, of course, for severe disease, it requires a combination of trimethoprim sulfamethoxazole with amikacin, imipenem, or linezolid. Then respiratory viruses also tend to cause severe infection in transplant patients. We see infections with influenza. In fact, H1N1 again has been happening, not just for transplant but otherwise as well. Then respiratory syncytial virus, human metapneumovirus, adenovirus. Do not completely rule out the possibility of co-infection, because it is not just a positive viral PCR which can exclude a bacterial or fungal disease. Both can coexist. So you must keep the possibility of co-infection in mind in such patients. And very important, infection control practices have to be reinforced and have to be adhered to very seriously. And of course, educate your patients and staff about vaccination, which is a very important aspect when you talk about viral infections. We just talked about mimics in brief, so do not forget mimics of infection, which can be pulmonary edema or transfusion related lung injury, diffuse alveolar hemorrhage, organizing pneumonia, post drugs like sirolimus, tacrolimus, radiation pneumonitis. So always keep the possibility of mix in mind, especially when you've started your patient on appropriate therapy, there's no response, or your clinical clues are telling you that there is a possibility of a non-infectious cause. So mimics should always be kept in mind. So now we talked about the transplant. Now the non-transplant immunocompromised. So many patients are not transplant recipients, but they have they behave as immunocompromised hosts. So you need to understand what all you need to see in these patients, what all you need to send. So you need to have CBC differentials. You need to have history of any steroid, biologics, or oncological drugs, any diabetics, any patients with liver disease, or you're seeing an unusual imaging. Who are your common non-transplant hosts? Patients with retroviral disease, chemotherapy, patients on chemotherapy, patients on high-dose steroids, rheumatological biologics, or any known primary immunodeficiency. So what would your initial assessment include? It would have your CBC differential, any particular drug history, especially with steroids, JAK inhibitors, chemotherapeutic agents, transplant-like drugs, any specific organ dysfunction, certain syndrome clues, any CNS, skin or adrenal lesions, any tissue invasion. If the story looks like AIDS but HIV is negative, you must check for the CD4 count always in such patients. The diagnostic pathway for a non-transplant patient would include the host clues. Never forget your history and examination, and you have to see your patient. You have to understand what the
ज़्यादा
patient is
ड्राई फ्रूट्स
complaining,
अभी
what
नहीं
is he
देना, बीपी
presenting in?
इंक्रीज कर देंगे।
Then what
Increase कर
syndrome,
देगा।
what organ are you dealing with? Lung, CNS, skin, genitourinary, or is it a
काजू-
disseminated disease? What is
BP
your
का main
HRCT
काजू
pattern
नहीं
showing
देना
you?
है।
काजू नहीं
And then
देना है।
accordingly,
बादाम,
send
किशमिश
appropriate samples for
और,
culture, PCR, histology, as well as
ये
biopsy
खजूर
in cases where it is
वो दे
needed.
सकते हैं। खजूर मैक्सिमम टू मैक्सिमम एक।
खजूर
Talk to
एक।
your
नहीं, ये
microbiologist.
अखरोट।
You need
अखरोट।
to
अखरोट एक।
discuss with your
खजूर
खजूर 2-3
microbiologist
दे
why
सकते
you
हैं।
could be
खजूर 2-3
suspecting
बादाम 2-3 दे
nocardia,
सकते हैं।
mold,
किशमिश दे सकते हैं।
mycobacteria.
हाँ।
When you're sending BAL, what all you want to be
किशमिश से
covered.
problem नहीं होती
In
ना,
case
इसमें
you
digestion।
have scanty
Diabetes है
material,
उनको?
then you
हाँ।
need
हाँ,
to
तो किशमिश
prioritize
नहीं दे सकते हैं।
based on your presentation of the patient what you
खजूर-
want your microbiologist
खजूर भी
to
बहुत
check first.
limited।
So unless you discuss with your
वो
microbiologist,
देंगे फिर
you
से
might
बता
not be
देंगे।
able to get the desired sampling
बादाम और
done,
अखरोट
especially when the
खा सकती हैं।
sample is
काजू
scanty.
बिल्कुल नहीं खाना है।
काजू तो बिल्कुल नहीं, बीपी बढ़ाएगा immediate।
काजू
Then
मत खाओ। काजू का
the
पैकेट
ICU
हमें
algorithm for an hypoxemic host. So
क्या नाम है?
once you
मैंने
recognize
जब से
the
काजू
defect,
खाना
you've
start किया
seen the
है,
imaging,
तब से
you've
तुम्हारी ये
set,
start हो रहा है बीपी का।
send the appropriate samples, you've started the bucketed empiric therapy. You need to review at 40 to 72 hours. So essentially, the algorithm
नहीं,
remains
तुम
the
एक डेढ़
same.
साल से खा रही हो ना।
Age है?
And based on the specific
65
tests and the diagnostic results that you get, you either narrow down and
Age
or
और
you
तुम्हारा
do a
उसके हिसाब
biopsy
से
in
लिखवा
case
रहे
you're not able
कि
to
तुम्हारी
get the
क्या है
diagnosis.
बताओ।
And remember one thing very important, whether it's a
एक ही टाइम देना
transplant or a
चाहते हैं या 2
non-transplant
टाइम
or a HIV or a non-HIV
नहीं, दो
host,
टाइम
you
खाना चाहते
have
हैं,
to
एक ही टाइम
achieve
खाना
source
चाहते हैं।
control, because source control again is a very important aspect
हाँ, तो एक ही
when
टाइम
you're
खाना
treating a
है।
patient with infection. Then duration
duration
of treatment for pneumocystis cerevisiae, we know it is with trimethoprim sulfamethoxazole for 21 days. For CMV disease, it is again 14 to 21 days. You may extend beyond 21 days
एक
if
महीना दे
the
दो
symptoms are still
और
persisting or the
बीच में
viral
बीपी
load
चेक
is
कर
still
लो।
high.
सभी
For
अच्छा है
aspergillus,
तो वो
at least 6 to
continue कर
12
लो।
weeks.
Just machine
Nocardia,
है,
6 to
3 बार
12
check
months.
करता हूँ,
May
फिर
require
average
longer
निकालता हूँ,
with
क्योंकि वो
CNS or
machine
disseminated
accurate
disease.
नहीं देती है।
For mucormycosis, weeks or 2
और
months.
कुछ नहीं
Plus
चाहिए उनको।
surgical controls. You need to get these patients
एक ही टैबलेट
operated.
है ना वैसे।
सिर्फ एक ही टैबलेट
वो एसिडिटी वाला नहीं किया है।
नहीं चाहिए।
Prevention,
वो तो पहले
like we
उनको
know,
थोड़ा
every
gastric हो रहा था,
discharge is a
उसके लिए।
prevention opportunity. So, pneumocystis prophylaxis for all patients post-transplant, HSCT, patients on prolonged steroids, and selected malignant as well as biological settings.
उल्टा और
CMV
नुकसान
prevention, prophylaxis and preemptive monitoring in transplant based on risk. Fungal prophylaxis for selected AML, HSCT, and solid organ transplant risk groups. Vaccination, you have to enforce vaccination for all patients. Annual influenza vaccine should be given to all patients. Pneumococcal and RSV where eligible. And you must vaccinate before the immunosuppression whenever it's possible. And always review your patient's medication because there can be drug-drug interactions. The patient may require renal dose modification and adherence checks. Prophylaxis always require adherence checks, which is also a part of prevention.
वो वॉकिंग तो जाती नहीं है।
वॉकिंग अभी मैं कभी
Then
कभी लेके जाता हूँ
traps,
रात को इधर।
you that can cause actually avoidable harm. You're anchoring on the first positive PCR or culture. You're trusting prophylaxis without checking adherence, absorption, and dosing. Waiting for the chest X-ray evolution instead of ordering an early HRCT. Must do an early HRCT and BAL in these patients. Don't wait. Delaying BAL and forgetting the mimics. Always remember non-infectious mimics for all your patients. So to summarize, define the host and the defect first. Transplant day alone is not always enough. HRCT pattern can guide you to the first differential before your culture returns at 48 to 72 hours. Send the day one diagnostic bundle together like we discussed. BAL should be done early and biopsy when needed, especially when you're not able to get an appropriate diagnosis. Non-transplant immunocompromise is common in patients who have lymphopenia on steroids, biologics, diabetics, liver disease, and myelodysplastic syndrome. At 48 to 72 hours, make an active decision to either stop, narrow down what to continue, and whether you need a biopsy or not. Thank you.
Thank you, Dr. Akanksha, for giving a recap of the last module. So we will now begin with the today's lecture, which is on the ICU device infections. And I have a great pleasure in introducing Dr. Deepak Govil, whom I know for last 30 years. He is an excellent human being, currently working as a vice chairman,
ಸ್ವಲ್ಪ ಗಂಟ್ಲೆ
Critical
ಇನ್ಫೆಕ್ಷನ್
Care
ಆಗಿದ್ದಾರೆ
Medicine, Institute
ಅದಕ್ಕೋಸ್ಕರ
of
ಜ್ವರ
Critical Care
ಐಸ್ಕ್ರೀಮ್
Anesthesia,
ತಗೊಳ್ತಾರೆ
Vedanta, the Medicity, Noida. He's been the past president of Indian Society of
Gurgaon, not Noida. Sorry, I missed that.
Sorry. Sorry. I will, let me correct it as well. Gurugram. And past Vice Chancellor of Indian College of Critical Care Medicine, past Controller of Examination, Indian College of Critical Care Medicine. He has been Director of the WinFocus ITO Delhi. He is ex-council member of World Federation of Intensive and Critical Care, the LAPTT,
ಇದು ಅಪರ್ ರೆಸ್ಪಿರೇಟರಿ ಟ್ರ್ಯಾಕ್ ಇನ್ಫೆಕ್ಷನ್
ECMO diploma.
ವಾತಾವರಣ ಚೇಂಜ್
His area of interest ventilation, hemodynamic monitoring,
ಬಿಸಿ ನೀರು
ultrasound, sepsis. He organizes lot of CMEs all throughout the year.
ಮತ್ತೆ ಸ್ವಲ್ಪ ಆವಿ ಕೊಡೆ
Very
ಸ್ವಲ್ಪ ಗಾರ್ಗಲ್ ಮಾಡಿ
dedicated teacher and is an excellent person. So I have a great pleasure in handing over to Dr. Deepak Goyal.
Thank you very much, sir, for kind introduction. So the next talk is by Dr. Amit and Dravid. He'll be speaking on diagnosis and management of CRBSI and CLABC. Dr. Amit is working as consultant in HIV medicine and infectious disease, Noble Hospital and Research Center, Pune, and in the Hospital and Research Center, Ruby Hall Clinic, Pune. He is the Director of Infection Control Program at Noble Hospital, Pune. He is the lead antimicrobial stewardship program. He is director at Sanvedana Foundation. He is the active member of National and International Infectious Disease Societies. He is the fellow of Infectious Disease Society of America. He is the member of American Academy of HIV Medicine and certified specialist for that. He is investigator of NIH funded international HIV research collaborations. He is the author of 100 plus peer reviewed guidelines and articles in different journals like Nature Reviews, Neurology Journal of Clinical Investigation, Lancet HIV Medicine, HIV Medicine, and so on. He is a recipient of multiple international research scholarship and Young Investigator Award. His research interests are HIV, CNS viral infection, HIV, TB co-infection, antimicrobial resistance, COVID-19, tropical infectious disease, and infection control.
Thank you.
His area of interest are HIV medicine, tuberculosis, multi-drug resistant bacteria and fungal, and infection prevention and infection control, antimicrobial stewardship. So I'll hand over the screen to Dr. Amit so that he can start his talk.
Thank you, Dr. Chawla. Thank you, Dr. Govil, and thank you, IDCCM, for inviting me for this very important lecture. And is my screen visible?
Yes.
So, thank you, Akanksha. It was an amazing lecture which you have given earlier and has made my job actually quite easy. So, I am going to talk about diagnosis and management of catheter-related bloodstream infection and central line associated bloodstream infection. We all know that catheter-related bloodstream infection constitutes an important cause of hospital-acquired infection and is associated with morbidity, mortality, and cost. CDC has estimated that there will be around 30,000 central line related bloodstream infections occurring in ICU in the US every year. In India there is no data, but we are 4 times their population. So I am sure we will be having at least 1 lakh and above central line related bloodstream infections in our ICUs. How do we define the devices? We define the devices as a central vascular catheter, that is a catheter which is placed in a vein and its distal end is located within a central vein. It is a short-term central vascular catheter. It includes non-tunneled even hemodialysis catheters. They are generally intended for short-term use, less than 30 days. And these include catheters which are placed in the subclavian vein, the internal jugular vein or the femoral vein. Then there are other lines, that is, which are called as PICC lines or peripherally inserted central catheters, which are inserted into peripheral veins, usually basilic or cephalic. Then there are long-term central catheters, which are surgically implanted central catheters. They have a tunneled portion under the skin and a cuff just inside the exit site. These catheters are intended for use longer than 30 days. So your chemotherapy recipients or sometimes hemodialysis catheters in patients who do not have an AV fistula, which can be used for longer than 30 days. And there are port placement as well, which is an implantable subcutaneous port or reservoir for self-sealing septum tunneled beneath the skin, and it is used in our chemotherapy recipients. So all these catheters we are seeing in our ICUs day in and day out, and when they get infected, that is when we have to make a medical decision to make in the ICU. So this is our tunneled catheter, tunneled hemodialysis catheter. This is our PICC line, and this is the port catheter, which is used, or portacap, which is implanted under the skin, and it's a reservoir through which chemotherapy is given, and they can last inside for months together. So these are the devices which we are talking about. So what are the definitions of infection which we are talking about? We will start off with the superficial infection. So first is the exit site infection. That means at the exit of the catheter, there is exudate, there is erythema, there is induration or tenderness, and sometimes there are negative blood cultures. So with leukemia, who are on myelosuppressive chemotherapy, they are at high risk of catheter-related infections as compared to solid tumors. Then patients with neutropenia or patients undergoing
दवा तो
allogenic
खाओ,
or
अभी
hematopoietic
दवा
stem cell
रहेगा आपके पास
transplantation,
में, बट
again
टाइम टू
are
टाइम
at high
खाओ.
risk of
हाँ,
CRBSI. Remember,
ठीक
the
से नहीं
reported
खाएगा,
rates
जल्दी
of
ठीक नहीं
CRBSI
होगा.
in implantable and tunneled catheters are lower, and that's why they are used for long-term use of infusions as compared to non-tunneled catheters. So your tunneled catheters for dialysis, tunneled catheters for chemotherapy infusion
8
have
तारीख को मुझे
lower
बता.
chance of CRBSI as compared to non-tunneled catheters.
वो
For
दवा खा के
students, I
5
would
दिन का था,
encourage
कितना
reading
बाकी
these
है अभी?
guidelines, which are published by the Spanish
खा ही
Infectious
नहीं
Disease
रहा है भैया
Society
तुम.
and the Spanish
हाँ,
Society for
वो तो
Internal
खत्म ही
Intensive
हो
Care
जाना
Medicine.
चाहिए था
They
पूरा.
give a ringside view of how to manage bloodstream infections because of catheters.
ये भी
So I have
एक
kept
ही
my
दिन का
talk as
बचना
question
चाहिए
answer
था,
so that
आज का ही बस
the
था.
students who are
1
attending
2
this
3
can
4 टैबलेट अभी भी बाकी है.
understand easily.
हाँ,
When do we call a catheter-related
दवा खाओ
bloodstream
भैया, नहीं
infection
खाएंगे
as
तुमको
complicated?
प्रॉब्लम में,
So
किसी और
the
को नहीं.
catheter-related bloodstream infection is considered complicated if you diagnose a catheter-related bloodstream infection, you start proper empiric antibiotic therapy, and despite 72 hours of appropriate antimicrobial therapy, the bacteremia just does not go up. Or there is presence of sepsis syndrome along with CRBSI. Or there is an intravascular hardware in place. So you have diagnosed CRBSI and the patient has a mechanical
दवा
valve
ऑलरेडी
or
है,
a
वही खाना
pacemaker
है
or
माँ.
an AICD in situ,
हाँ,
which
वो
makes it
खत्म होना
a
था, वो खा ही नहीं रहे तो क्या
complicated
करेंगे?
catheter-related bloodstream infections. Or there is not just CRBSI, but there are metastatic disease like endocarditis, septic emboli in the lungs, osteomyelitis, or suppurative thrombophlebitis, which makes it a complicated CRBSI. Or any CRBSI in immunocompromised patients should be treated as complicated catheter-related bloodstream infection. What are the most common microbes which cause CRBSI in India? These are the skin pathogens. So remember, because it goes in through the skin, microorganisms which colonize the skin are responsible for CRBSI, and they use the catheter insertion site or the hub of the catheter as a portal of entry into the bloodstream, and there they form biofilm, and from there starts from there is the beginning of CRBSI. So what are the commonest organisms we can see? Commonest are coagulase negative staph. Again, these are skin contaminants. They are present on the skin of ICU patients, and they can get and cause CRBSI. Second is Staphylococcus aureus. Again, another skin commensal. Then Enterococcus faecalis is the third most common. Now we are gradually seeing even gram-negative organisms causing CRBSI. So your Klebsiella, your E. coli, your Pseudomonas are now increasing as the causative agents of CRBSI. We are also finding fungi, and I'll tell you in which particular context we get Candidemia as the etiologic agent of CRBSI. So approximately 40 to 80% of CRBSI are still caused by Staph aureus and coagulase negative staph. But as I said, Pseudomonas aeruginosa and Candida are less common but important causes of CRBSI. And why are they important? because multi-drug resistance is increasing in these bacteria, because of which the antibiotic choice which we are going to use for treatment of CRBSI is going to change completely. What is the clinical presentation? Altered temperature. So the patient has either fever or hypothermia, he has hypotension, he has tachycardia, he has altered perfusion, tachypnea, and sometimes even altered mental status. Clinical suspicion should also be raised when there are abnormal skin findings, which I have already mentioned, like erythema, pain, swelling or discharge around the CVC exit site, the subcutaneous tunnel or the port pocket. However, absence of skin findings does not rule out CRBSI. So any patient who has a catheter in situ in the hospital, say for 7 to 14 days, coming to you with fever, high grade fever or hypothermia, hypotension, tachycardia, tachypnea, we should consider CRBSI as a differential for the cause of fever. How do we then diagnose it? The first thing about diagnosing CRBSI is obtaining blood culture. So blood culture should be drawn in any patients with CVC and a clinical suspicion for CRBSI. One blood culture set includes 2 bottles, one aerobic and one anaerobic. Blood culture should be obtained prior to initiation of antibiotics. However, if the patient is unstable or critically ill, do not wait for sending blood cultures, and if it's at night, the blood culture facility is not available, antimicrobial therapy should be initiated immediately, because we don't want the patient to become serious because of sepsis syndrome. In adults with suspected CRBSI, at least 2 sets of cultures should be drawn simultaneously. So one set should be taken from the central venous catheter and one set should be taken from the peripheral vein. If the peripheral veins cannot be found, so in patients who are on dialysis regularly, many times their peripheral veins are completely fired, and the left hand we cannot use the veins because there the AV fistula is going to be put. Then we can also use multiple lumens from the multi-lumen catheter and send 2 sets of blood cultures from there. So ideally 2 sets of blood cultures simultaneously. One set is of 20 ml, one aerobic, one anaerobic. So 20 ml from the central line, 20 ml from the peripheral line. If a peripheral line is not available, patient is very obese, patient is on dialysis and the left hand cannot be used, and he has a multi-lumen catheter, then 1 set each from 1 lumen should be sent for diagnosis. What is differential time to positivity? That is essential for diagnosis of CRBSI. Differential time of positivity is the time when the blood drawn from the CVC came positive and the time when the peripheral vein blood came positive. So if there has to be a lag of 2 hours between the growth of the same microbe from the peripheral line as compared to the central line. So the central line has to grow faster and the peripheral line has to grow 2 hours later. If that is the differential time to positivity, then it confirms CRBSI. However, if DTTP or differential time to positivity is negative, it still does not rule out CRBSI, especially in cases which are because of Staph aureus or Candida CRBSI. There you might not have a differential time to positivity. So yes, differential time to positivity is great. If the central line blood culture grows 2 hours earlier than the peripheral line blood culture, then our diagnosis of CRBSI is done. However, if it is not so, still we can diagnose CRBSI, especially in organisms like Staph aureus and Candida. This differential time to positivity cannot be identified. Guideline after guideline is saying that we should not wait for the entire blood culture and then the sensitivity to come, and we should run rapid microbial identification like Malditoff or BioFire on our positive blood cultures, because it reduces time to identification of microorganisms and has clinical impact of management of patients with suspected bloodstream infections, especially in ICU where every hour is important. Waiting for endlessly for the blood culture to come positive might not help, and here rapid microbial identification with Malditoff or BioFire might be of great benefit. What about catheter tip cultures? People always ask me whether I should send a catheter tip. Remember, catheter tip culture should be obtained in any CVC removed due to suspicion of CRBSI. So first there has to be a suspicion of CRBSI. Just for surveillance, do not send catheter tip culture. The patient has to have a catheter in situ. Patient has to be in the hospital for say around 7 to 14 days. After institution of the catheter, the patient should get fever, high grade, hypotension, tachycardia. He is shifted to the ICU. There, you are suspecting CRBSI. You are going to remove the catheter anyway because 14 days of the catheter are over. the blood culture still has not come positive, there you can send a catheter tip culture. How much catheter you have to send? 5 centimeter segment of the catheter tip should be sent. A roll plate technique is used for culture, and if there are more than 15 colony forming units per plate grown, then it is suggestive of infection. Again, the same organism has to grow in the central venous catheter blood culture, same organism has to grow in peripheral venous blood culture, and the same organism has to grow in the catheter tip culture. Only then we can say that this is CRBSI. So yes, catheter tip culture, if the blood culture diagnosis has not been done and you're anyway going to remove the catheter, you are suspecting CRBSI, then you can send catheter tip. The catheter tip, just like how much blood culture has to be sent, almost 40 ml has to be sent, 20 ml from central line, 20 ml for peripheral line. Here also 5 centimeters segment of the catheter tip has to be sent, and they have to be told that you use a roll plate technique for semi-quantitative culture, and growth of more than 15 colony forming units has to be there to indicate that this is true infection. So, how do we diagnose CRBSI? It is considered definitive when 2 blood samples, one from the CVC, one from the peripheral side, grow the same organism with significant differential time to positivity. However, CRBSI can be presumed when the CVC is in place and there is at least one positive blood culture growing a pathogen from any side in the setting of clinical signs of infection with no other apparent source of other infection. So, presumed or definitive, we have got to treat CRBSI. So, as I said, many times there is a problem to know whether this is really CRBSI. Why? Because as I said, majority of the organisms causing CRBSI are skin contaminants, that is coagulose negative staph. Many times it happens that the blood culture grows coagulose negative staph, and the microbiologist says that this is skin contaminant. But here, if you are a clinician, you are in the ICU, you know that you have sent a central venous blood culture and you have sent a peripheral vein blood culture. Maybe the central vein blood culture has not come positive, but the peripheral vein blood culture is positive, and you are suspecting CRBSI, you want to remove the catheter. There you have to know that sometimes it's not contaminant, but it is true infection. It is a potential CRBSI, especially for coagulose negative staph, if in the presence of clinical symptoms consistent with potential CRBSI, a treatment for infection is warranted. So remember, every time if the blood culture grows coagulose negative staph, don't dismiss it that this is a contaminant. It might be an organism causing CRBSI. When can a catheter be retained? So many people ask me that is it always necessary that once CRBSI is diagnosed, a dialysis catheter is in situ, the central vein blood culture has grown one organism, the peripheral vein blood culture has grown one organism, then is it always necessary that the catheter has to be removed? Because multiple times in dialysis patients, in obese patients, in patients with severe burns, removing the catheter is not feasible because another site might not be found. So, immediate removal of CVC is not routinely recommended when the patient is hemodynamically stable, when the patient does not have autoimmune disease or is not on immunosuppressive therapy, when he does not have intravascular foreign bodies in his body, is not an organ transplant recipient, and there is no suppuration at the insertion site, or there is no bacteremia or fungemia. So, we don't need to worry, especially if it's going to grow coagulase negative staph, which are simple skin contaminants where we can treat through. Remember, immediate removal of severe CVC is not routinely recommended. Then the question arises, can we perform a catheter exchange over a guide wire? Many people want to do it because, again, the same thing, the patient is morbidly obese, he has extensive burns, he has severe coagulopathy, he does not have a documented catheter infection, or maybe has a presumed CRBSI. Then routine replacement of CVC by a guide wire exchange is not recommended. Strategy is associated with a very high risk of infectious complications, and the ICU team should know this. Guide wire exchange of CVC is contraindicated in patients with documented catheter infection. So, if your central venous blood culture and peripheral venous blood culture are positive, then you cannot do a guide wire exchange. Guide wire exchange should be restricted to patients with very difficult venous access, like extensive burns, morbid obesity, severe coagulopathy, and without documented catheter infection. So, where there is presumed CRBSI, again a meticulous aseptic technique and culture of the catheter tip are mandatory. What should be done if the catheter tip culture is positive, but the blood cultures are negative? And sometimes it happens that you have sent a central vein blood culture, you have sent a peripheral vein blood culture, both come negative. and you are already going to remove the catheter, you are suspecting CRBSI, and the tip culture has been sent, and that grows Staph aureus. So remember, if Staph aureus grows in catheter tip culture, then antibiotic treatment should be given to patients for around 5 to 7 days who are culture tip positive for Staph aureus and negative for blood culture. In non-neutropenic patients, especially without signs of valvular heart disease, presence of catheter tip culture for Candida again is a problem. There you have to evaluate. It could be that Candida is causing the CRBSI, or it is just a contaminant. So you have to take everything in mind. And if these two organisms are there, Staph aureus and Candida, you can think of treating for 5 to 7 days, even in presence of positive catheter tip cultures and negative blood cultures. There are no clear recommendations for any other organisms for positive catheter tip cultures. So remember, what is the empirical antimicrobial therapy now for CRBSI? Now we have diagnosed it, we have sent the blood cultures, the central line blood culture has come positive, the peripheral line blood culture has come positive, the DTTP is positive, they are both growing the same organisms. It is now before that, what empiric therapy should be given? So before you diagnose it, if it is suspected, then antimicrobial therapy should be started as soon as possible once you have sent the cultures. We use a bactericidal agent active against Staph aureus and coagulase negative staph, because these are the most common organisms which are going to cause CRBSI. Especially if patients with sepsis or septic shock, it should be started immediately. Vancomycin is recommended for empirical therapy in patients with suspected CRBSI. Teicoplanin is not recommended because coagulase negative staph sometimes have reduced susceptibility to teicoplanin. So if you are suspecting CRBSI, you have sent blood cultures, both central line and peripheral line, then vancomycin should be the empirical drug of choice. If the patient has a very bad septic shock, or he has an acute kidney injury, or he has had a recent exposure to vancomycin, then we can use daptomycin as well at the dose of 6 to 10 milligram per kilogram. Again, linezolid should not be used because it is a bacteriostatic drug, and hence it is contraindicated as empiric therapy for CRBSI to start off. So once you have suspecting CRBSI, you have sent cultures, then you should be hammering Staph aureus and coagulase negative staph, and vancomycin should be your drug of choice. When should you give empirical coverage for gram-negative bacilli or for fungi? So remember, now in our ICUs, CRBSI because of gram-negative bacilli like Klebsiella, E. coli, Pseudomonas are increasing. So when do we give empirical coverage for gram-negative bacilli? Once when there is severe hemodynamic instability. If the patient is in septic shock and CRBSI is suspected to be the cause of septic shock, or the patient has neutropenia or hematologic malignancy, or he has a solid organ or bone marrow transplant in which we are suspecting a CRBSI, or he has a femoral catheter in place. Remember, femoral catheters, central vein lines put into the femoral vein have very high risk of gram-negative bacteremia, and if that is in place, then empiric coverage with gram-negative bacilli should be initiated. Again, prolonged ICU admission, we should suspect that gram-negative bacilli could also cause CRBSI. Which are the agents which we can use? Normally, it is recommended that we use piperacillin tazobactam or carbapenems or fourth generation cephalosporins like cefepime. Again, the hospital antibiotic policy and what are the bugs growing in CRBSI in the particular hospital is more important. In our hospital, we use piperacillin tazobactam plus vancomycin as empiric coverage for suspected CRBSI because of gram-positive and gram-negative infections. When do we add empiric coverage for fungi? So sometimes, as I said, even Candida can be a cause of CRBSI. So there are certain situations where the patient is hemodynamically unstable, he has a catheter in situ, and on top of that he is taking total parenteral nutrition, or already has had prolonged use of broad spectrum antibiotics, or has had malignancy, or has femoral catheterization, or has colonization because of Candida species at multiple sites, or has had esophageal perforation, or has had a recent abdominal surgery with recurrent GI perforations or anastomotic leaks or tertiary peritonitis, there the risk of candidemia is very high, and here CRBSI because of Candida can also occur, because of which empirical coverage because of fungi, empirical coverage against fungi have to be introduced. Is there any role of any biomarker? Yes, for empirical coverage of fungi, before starting the empirical coverage with antifungal therapy, we can send biomarkers like 1,3-beta-D-glucan because they come faster than a fungal culture. They are more sensitive than a blood culture for fungus, and any value above 80, if two consecutive serum BDGs are above 80, then there is suggestive of invasive candidiasis in high risk patients and we should start treatment. On the other hand, if the BDG is negative and it comes less than 80, it more or less rules out any candidemia, and discontinuation of empirical antifungal therapy is then strongly encouraged. So although it does not have good positive predictive value, it definitely has a negative predictive value, and if the BDG is less than 80, we can stop antifungal therapy empirically. So now we know when to start empiric therapy. The most common empiric therapy which we are giving is vancomycin. If there is risk factors for gram-negative infections, we are adding piperacillin tazobactam or meropenem. If it is empiric therapy for fungus or we are suspecting candida as a cause of CRBSI, we are adding caspofungin or sometimes liposomal amphotericin B. More or less, we are adding caspofungin or micafungin. So now, what is the directed therapy or optimal duration of treatment for CRBSI because of staph aureus? So now the blood culture has come. The empiric therapy treatment is over. We have given 2 to 3 days of empiric therapy. Now the blood culture has come and it shows that it is methicillin sensitive staph aureus. So the treatment of choice for methicillin sensitive staph aureus is flucloxacillin or cefazolin. So your vancomycin has to stop now. If MSSA comes or methicillin sensitive staph aureus comes, then vancomycin is not a good drug for MSSA. Many times physicians feel that all staph aureus have to be treated with vancomycin, but it's not so. MSSA CRBSI can be deadly or fatal if we don't downgrade to drugs like flucloxacillin or cefazolin. Patients who are allergic to flucloxacillin or cefazolin can use daptomycin or vancomycin, but again the efficacy of vancomycin for MSSA is lower than that of flucloxacillin and cefazolin. So cefazolin or flucloxacillin almost 8 to 12 gram per day, or cefazolin 2 gram 3 times a day can be initiated as directed therapy against MSSA. Teicoplanin can also be a valid alternative, especially in cases of severe adverse events with the use of vancomycin. What about MRSA? MRSA, vancomycin is the treatment of choice. So for MSSA, flucloxacillin and cefazolin is the treatment of choice. For MRSA, if the blood culture, both central line and peripheral line, goes methicillin resistant staph aureus, then vancomycin is the drug of choice. If the patient has vancomycin allergy or vancomycin AKI, then even teicoplanin can be used as a valid alternative. So for MSSA and MRSA CRBSI, blood culture should be obtained after 72 hours of antibiotic therapy and to confirm that sterility has been achieved. So for staph aureus, blood culture sterility is very, very important. Once MSSA is grown or MRSA is grown, once MSSA is grown, we put the patient on flucloxacillin or cefazolin. After 72 hours of antibiotic therapy, we confirm that the patient has become sterile for MSSA or MRSA. For MRSA, we use vancomycin or teicoplanin. What is the recommended directed therapy and optimal duration for CRBSI because of cons or coagulase negative staph? So remember, we were talking about MSSA or MRSA, staph aureus. Here we are talking about coagulase negative staph. So again, if the coagulase negative staph or cons, as it is called as in blood culture report, is methicillin sensitive, then the treatment of choice is flucloxacillin or cefazolin. Again, if it is methicillin resistant cons, then vancomycin is the treatment of choice. Teicoplanin is recommended in the case of serious side effects associated with vancomycin. So the treatments do not change, but the organisms we have to identify whether it is MSSA, whether it is MRSA, whether it is MR cons, or whether it is methicillin sensitive cons. Also, if the blood culture grows an organism which is Staphylococcus lugdunensis, then it should be managed as staph aureus CRBSI, because again it can cause peripheral site involvement just like staph aureus can. Now the third organism, what is the recommended directed therapy for Enterococcus? So if the blood culture grows Enterococcus, then it should first is to remove the catheter and start an active antimicrobial. So for staph aureus, for Enterococcus, for Candida, for Pseudomonas, we do not keep the catheter in situ. We remove the catheter. There is no chance of treating through, no chance of keeping the catheter in situ. The catheter has to be out and antimicrobial has to be started. Ampicillin is the drug of choice for susceptible isolates. However, if it is ampicillin resistant, then vancomycin is the drug of choice. And if it is vancomycin resistant, then daptomycin is the treatment of choice. Despite all this, the duration of treatment has to be 14 days from the culture sterility. So once the culture is sterile, 7 to 14 days from that, we have to give antibiotic therapy to clear the bacteria from the blood. What is the recommendation for gram-negative bacilli? Remember, directed therapy for gram-negative bacilli should be chosen on the basis of susceptibility result. As I said, now E. coli, Klebsiella, Pseudomonas, causes of CRBSI are increasing. The appropriate duration is at least 7 days. But first, we need to know what is the organism and how resistant it is. Why? Because I am going to heavily borrow from the 2024 antimicrobial resistant guidelines of gram-negative infections, and I ask all the students to read these guidelines if you want to know how to manage gram-negative infections in ICU well. Why is it important? Because gram-negative bacilli, unlike gram-positive foci, produce what is called as carbapenemases. These are of 4 classes A, B, C, D. The worst amongst them are metallo-beta-lactamases, which are common in India, and just like the gram-negative bacilli is important, the carbapenemase it produces is also very, very important, and that is going to decide what antibiotic you are going to use. So if it's just ESBL producing Klebsiella, then carbapenems are the drug of choice. Your meropenem or altapenem can be given for 7 days. If it's a Klebsiella pneumoniae carbapenemase producing Klebsiella, then ceftazidime avibactam is the drug of choice. If it's a metallo-beta-lactamase producing Klebsiella, then ceftazidime avibactam plus aztreonam is your drug of choice, or now avibactam aztreonam is the drug of choice. If it's Pseudomonas aeruginosa, difficult to treat, carbapenem resistant, then again ceftazidime avibactam is the drug of choice. And if it is Acinetobacter, which is a rare cause of CRBSI, there a combination of sulbactam, minocycline and polymyxin B can be used for CRBSI. So for gram-negative bacilli, the culture which we send, the centerline culture, the peripheral culture, the organism which grows, not just that is important, what carbapenemase it is producing also is very, very important to identify what antibiotic can be given. Remember, the guidelines have now said that if you are suspecting CRBSI because of gram-negative organisms, the dose of meropenem can be increased to 2 gram 8 hourly and can be infused slow over 3 hours if you are suspecting CRBSI because of gram-negative infections, especially ESBL E. coli. And ceftazidime avibactam, again, they have to be given simultaneously and slow over 3 hours to achieve coverage against metallo-beta-lactamase producing organisms. So this is the case which I am going to present. This guy was a patient who was having dengue and he was admitted in an ICU outside because his platelet count had gone low. So he was given, the platelet count had reached 25,000, for which he was given dexamethasone. Once dexamethasone was given, the platelet count increased, the patient went home, but he came back to us with fever and cough. And this was the CT scan, and as you can see at the CT scan. So you can see here he has developed a cavitatory pneumonia, and once we sent a sputum culture and a ball culture, it grew mucus. So because of the steroids given for the dengue, especially within the first week, the patient had developed pulmonary mucormycosis. The patient was put a central line. He was started on liposomal amphotericin B plus posaconazole. After 21 days of liposomal amphotericin B and posaconazole, the patient started developing high-grade fever. So we sent a blood culture, and as you can see here, the blood culture, and as I said, rapid molecular diagnosis has to be useful. So once the blood culture flashed positive, we sent it for biofire, and the biofire blood panel showed that he had a Klebsiella pneumoniae in his blood, and that was NDM producing. So because this patient was in the hospital, had a central line, was getting treated with liposomal amphotericin B plus posaconazole, he had developed a CRBSI because of gram-negative bacilli. Both his blood culture from the central line and peripheral line had come positive, and within 24 hours of the blood culture flashing positive, because we had access to biofire, we knew that the organism was Klebsiella pneumoniae, NDM producing. So in addition to liposomal amphotericin B plus posaconazole, we had to put him on ceftazidime avibactam plus aztreonam, and luckily within 7 days the CRBSI
But
was
like
cured and the
intraventricular period
treatment
is
for nuclear
hardly
was
80
about.
days.
you have to
So,
meet to gynecologist.
what is the
It is
recommended
not,
directed therapy and its
if it
optimal
is
duration for
25 days
CRBSI
plus
because
it
of
is there,
Candida?
then no
So,
problem.
in patients with
If
Candida
it is less
species,
than 25 days,
de-escalation can be
something
done. So,
going on.
normally we
Maybe
give it
hormone
for
change,
14
maybe
days. So, if
PCOD,
you diagnose Candida
or some
as a bloodstream
inflammation,
infection,
Okay.
the treatment
thickened
of choice is IV
endometrium,
caspofungin,
or
IV
maybe some
micafungin,
other
or IV
reason
anidulafungin.
So you
Once
have
the
to meet
patient
to
is
gynecologist.
hemodynamically
So
stable
after
and there is
delivery,
no
the
obvious
residual
metastatic
period.
complication,
No, after
we can
delivery,
scale down to
sometime it will be
fluconazole
there,
if the
but it will
fungus
come
is
back on
sensitive to
track.
fluconazole. And it's
It is
after the
23
first
It
set
is
of
not
negative
there.
blood culture.
You
So
have to meet.
again in candidemia,
Okay.
all
Suppose
intravascular
everything is
catheters.
normal,
So for Staph aureus,
then also
Pseudomonas,
you have to be
and for
cross-check for
Candida,
thyroid and
all catheters
abdomen.
have out. While
Okay.
for cons,
For
we can
some,
get away with
at least
treating through
3-4
and keeping
years.
the catheter inside.
If it is anything, it is there, you have
What
to
can
take
be the
treatment.
complications? So there are complications,
Food, water,
especially if
you
you
have
have
to
Staph
very
aureus
careful.
or if you have Candida in the as the cause of CRBSI. The most common
And
is
one more thing, doctor.
if there is a
My
prosthetic
baby is
heart
going
valve,
to go for a
pacemaker
play
or
school.
ICD,
So
then
she's not
persistent
ready to go to
bacteremia
school
can
in the
cause
morning time.
endocarditis.
And
So
I'm
most
getting
common
later to get
is
ready.
endocarditis,
Sometimes
especially
I
if it's
get
Staph aureus.
so much
It
of
can cause
tension and
endocarditis.
I
We
feel
might
little
need
bit
a
of
transient
drowsy, tired.
esophageal echo
That
Is
is
that
to rule out
because
endocarditis. So
because
just
of
CRBSI,
stress. You
you
should
can,
not take lot of stress.
if you're lucky, you can get away with just
That
CRBSI.
Every
But
day
remember, if it's
morning,
Staph aureus
actually.
bacteremia, then it's
weakness
very
also it
likely
will
that
make
it
that
can cause
stress.
Staph aureus
Timely
endocarditis.
food,
If it is
proper
Candida,
food,
again it can
proper
cause
sleep.
endocarditis.
Yeah,
It
don't
can
take
also
so
cause
much stress.
retinitis,
So
chorioretinitis, because
hardly every
Candida
morning
loves the
I
heart
can
valves.
feel like
Candida loves
suddenly
the
the drowsy will
retina
come to me
where
and
there is
Then
high
it will
blood
get
supply.
correct.
So it can old male,
If
he
it
was
is normal,
diabetic,
it is a stress.
hypertensive.
Okay.
He had
And
a
weakness.
IJV hemodialysis catheter in
Weakness when
situ
it
and he
will
was
come, then
taking
you will take
dialysis
less
since last
water,
4
more
months.
timely
He
food,
presented to
more
us with
proper
high
sleep.
grade fever since last 12 days.
Proper sleep, timely food,
When we
drink
sent his
more
blood
water,
culture,
like
the blood culture both from the
you
central
take this
line
medicine
and
for
the peripheral
timely.
line grew
For
called
period, you
Candida
have to go to
auris.
gynecologist.
His creat was
Yeah, sure.
6.7. Rest all
This is top
investigations were
300 mg
okay.
morning night.
The
Last
blood
100
fungal
mg
culture
stomach
came and
morning
the
night.
Candida
Both are
auris was
after food.
sensitive to azoles,
Phantom DSR
echinophenidins and
morning night
amphotericin
before
B,
food.
while the
This
blood
you take
bacterial
for 3
culture was
days.
sterile.
By chance, little
When
bit
we
you
did
may
his
take 2 more
2D
days
echo,
extra.
you can see
Because of
the
cycle,
tricuspid
dose
valve
it
has a
will be
very,
lesser.
very large vegetation. So
Exercise
just like
take
Staph
today.
aureus, Candida,
If tomorrow you will
CRBSI
feel any
can
body
end up
pain, no pain
causing
and all, take.
tricuspid
Otherwise,
valve
no. Because
endocarditis. So
cycle
there
it
was a
is there, we
large
can't give more
tricuspid valve
painkillers.
endocarditis.
Okay, okay.
And again,
And do
I would
little
like the
gargle.
students to
Okay,
read these
sure.
guidelines,
Thank you.
which are the IDSA Candida guidelines. They will give you a very good view of how to manage Candida in the ICU. And the treatment for Candida endocarditis is liposomal amphotericin B plus flucytosine or high dose caspofungin. So that is what we did. And once the patient
I was
stabilized,
taking
we
this
downgraded him
antibiotic after
to
you take it away
fluconazole.
for
So
the throat
these are the
problem.
guidelines. I
And
would
it's working
recommend
very
all
bad on
students
me.
to read these
2 days I
guidelines
had
because
Okay.
Candida again, the treatment for
Okay.
CRBSI is different and the
Then you
treatment for
take half.
metastatic complications is
Half.
also different.
Half morning, half night.
So the question is,
Because some
should
people,
the antimicrobials be
erythromycin,
administered
it
IV
is
for the
common
entire
symptom.
course? No.
Oh, I actually
Once the
vomited
patient is
couple of times.
hemodynamically stable, he is
Any
afebrile,
antacid
the
I
catheter is
But
out,
that was in the
and
morning.
the
take
patient
a
has
morning
no
and
other
night,
issues.
both the time
There is no exit site
This also
infections.
morning
We
and
can
night.
draw therapy. So in cases of MSSA, we can use fluoroquinolones plus rifampicin. In cases where gram-negative bacillus is sensitive to fluoroquinolones, we can downgrade. Should we take a follow-up blood culture? I've already mentioned this. For Staph aureus and for Candida, we take a repeat blood culture at 72 hours. The 72 hours blood culture has to be negative, and then from there on for 14 days, we give treatment for CRBSI. I will leave antibiotic lock therapy because I think my next speaker will be speaking about it because it is about prevention. The thing is now that you have removed the catheter.
Dr. Amit, I think we should wind up. Its
Yes,
time
sir.
is, yeah.
Yes, sir. Last 2 slides. So, when to place a new central venous catheter? 48 hours after first negative blood culture, we can start treating. So, wait for 48 hours after the first negative blood culture, and then you put a new femoral catheter or a new venous catheter and start treating. And finally, when do you consult an infectious disease service? Remember, for Staph aureus bacteremia, consulting an infectious disease expert reduces the mortality by almost 56%. So if you have Staph aureus, Enterococcus, Pseudomonas or MDR pathogens or Candida species, do involve an ID guy. Patients where catheter removal is not an option and you want to treat through, involve an ID guy. Patients with cardiovascular implantable electronic devices or orthopedic or endovascular hardware, please involve an ID guy. And patients with bacteremia lasting more than 72 hours, please involve an ID guy. So that is all, and thank you for patient listening.
Thank you, Dr. Amit, for exhaustive talk. I request all the delegates to please put their questions in the chat box so that we can discuss all the questions after the this second talk. So the second talk is by Dr. Parul Kodon. Dr. Parul is talking about the ICU infection control bundles and MDRO containment. She is presently working at Harlem Hospital, New York City Health and Hospitals, and Columbia University. Previously, she was faculty at All India Institute of Medical Sciences, New Delhi, Lady Hardinge Medical College, and consultant at ICMR, New Delhi. She has got more than 100 publications and book chapters in her name. She is previously at Irne Travel Harris Scholar in 2022 to 24. She was the chair of the Implementation Science Group and lead editor, Yale Journal of Health Policy, Law and Ethics at Yale University. She has got the TAE Excellence Award 2020 for outstanding training by the European Society of Clinical Microbiology and Infectious Disease, and a scholarship training award by the ECDC 2022 RSTMH Student Ambassador India in 2019. So with this, I hand over to Dr. Parul.
Thank you, sir. Can you see my slides now? Are my slides visible?
Yes, ma'am, your slides are visible. Make it the full screen. Yeah.
Thank you, sir. So hello everyone. Thank you Dr. Amit and Dr. Akanksha for speaking before me, because most of the things which I wanted to cover are already covered, and we've spoken about infections. We know about gram-negative, gram-positive, candida, significant bugs all over the hospital which continues to threaten it. And what I will be doing will be just summarizing what we have kind of discussed and something which you all know, but I would like to re-emphasize that. So healthcare associated infections. When we talk about healthcare associated infections, typically we've been talking about nosocomial or hospital acquired infections, which is infection which occurs in a patient and is not present or incubating at the time of admission. That is why classically a window of more than 48 hours after admission is taken for the purpose of definition. However, this umbrella has been broadened now, and we call it healthcare associated infection to encompass the things like IV lines given at house, dialysis facility, or any smaller facility other than the hospital where an healthcare associated delivery was given. The global burden is huge. I can go over statistics and tell different stats from different countries, but I will just say something very simple. 136 million cases worldwide every year, risk in developing countries 20 times higher. Just very simple maths. Before we finish this talk, there'll be at least 15,000, more than 15,000 cases across somewhere getting these infections. And that is why it is very, very, very important to give it a thought. We know about all the great antibiotics, we know about all that we can do, but it definitely increases morbidity, it increases mortality, it prolongs hospital stay, it increases the cost. When we talk to US, they talk about statistics of $28 billion to $33 billion in excess of the healthcare cost. But taking you down to your very own experience, a simple case, something like Dr. Amit discussed, or all of you would have seen in your daily practices. A 56-year-old man who underwent an uncomplicated laparoscopic cholecystectomy. On day 5, he developed fever, it was UTI, sepsis, he grew carbapenem-resistant Klebsiella, he spent 38 days in ICU, and his total bill was over 38 lakhs, but the complications that went on took the course downhill, and what actually caused death was not the initial thing, but these healthcare associated infections. So one missed hand hygiene, one unnecessary catheter, one small miss about the delayed line removal which we talked in the previous one unnecessary antibiotic looks just so trivial in our daily talks. When we talk, we don't even consider we just missed our hand hygiene today. But if you see the small chain of small misses, it can actually skip the heartbeats by various ways and can even lead to death. And that is why I just want you to spare few minutes to discuss about how important the hospital infection control is. Talking about this entire protocol, which is very complicated, we talk about HIC policy, about frontline healthcare workers, about portal of entries, about involvement of labs, microbiologists, antibiograms, about ID infections, also talking to administration. Leadership has to take a lot of roles, talk about safety programs, enhancing incentives for this, make an action plan, but altogether it's a very complex process, and every single person who enters the hospital, whether it is a doctor, it's a nurse, it's a healthcare worker, a person who helps us pull the trolley, a person who helps us guide us inside, the guard, every single person has a big role in this. But talking about the very beginning of this, Mr. Semmelweis, who was in 1818 a practicing obstetrician in Austria, he said that he had a very high maternal mortality because of the failure of doctors to wash hands. And at that time, it was considered a big blow to the doctor practice, where it was thought germ theory was its in infancy, was not established by that time. And when he said that doctors can potentially transfer the infection, he was put into asylum, he was labeled psychiatric, and there was a huge outcry. Years later, even today, let not the ego of any one of us as being the healthcare provider ever come when we are talking about hand hygiene. When the infection control team comes and points mistakes, it is irritating, but that is what is most important to save lives. This is the old data from 1861, but even today, if we see, the rates of these infections are growing up. So whether we talk about this data from 1861, 1985, or the present day data from most ICUs, healthcare infections still cause a major cause of mortality. We have universal infection precautions plus body isolation, which started in 1985, and we have moved on to something called standard precaution, which includes hand hygiene, personal protective equipment, respiratory hygiene and cuff etiquettes, needle, stick and sharp injury prevention, storing our medication with safety, cleaning and disinfecting devices, placing the patient appropriately with appropriate cohorting and waste disposal at the proper time. The entire standard precautions would actually need to go into details of all of these, but we'll kind of discuss most important things from the MDR point of view. When you enter an ICU, this is a scene from a Chicago hospital which shows all the contaminated surface in a place which was leaked. And even after that, there were so many patient contact places where a VRE positive environment was found. And that is why it is very important to take care of our hand hygiene. There are a lot of places, if we do not take proper precautions or if we do not follow proper steps of hand hygiene, especially the fingertips, the finger webs, the palms and the thumbs, which can cause very significant infections. So to save lives, if from the entire text of what I say today with information, non-information, if I have to give you one important advice, I would tell you to please do your hand hygiene steps properly, and we will go through them in the subsequent texts. So causing about the chain of infection, we have the hosts, about which we have been talking about, and how can we make the host better. We talked about the immunocompromised host today at the starting. A proper isolation, immunization, nutrition, all that is a part of comprehensive care plan. And we as physicians are equally important to target this and address these issues. Appropriate immunizations or anything which can make our host immunity better is the part of infection control process. Reservoir, which includes disinfection, sterilization, proper waste disposals, decolonizations, so that our environment is clean. Transmission, most importantly from hand to hand, and taking appropriate precautions to prevent transmission as the need be, whether it is hand hygiene, whether it is PPE if needed for a airborne isolation and standard precaution based on the MDRO organism. So Previously, it was believed that many of these infections are inevitable. If patient comes to the hospital, he has to get some infection. We can do something to change it. But there have been studies and there have been documented evidence that if we try hard, each one of them is potentially preventable unless we say or prove it otherwise. And that is why CDC has put it in the list of a winnable battle. The spectrum shift is to save lives by winning this battle. So each infection is now considered potentially preventable unless it is proven otherwise. So, as we talked about the reservoir or the agent, we need to be careful about the sterilization, disinfection, and the waste management. Then, based on the transmission mode, we need to take the surveillance accordingly, whether we need to put the patient in positive pressure unit, negative pressure unit, would decide the air handling based on the airborne precaution of the organism. The portal of entry is what we'll be focusing the most today, and which was also the previous talk, which was the skin and soft tissue infection, catheter related bloodstream infection, WAP bundles, and catheter associated bloodstream infections. And as we talked about, making our host most improve immunity by vaccination, chemoprophylaxis, and special precautions which might be required in special population. So going over the same thing again, this is our infection control bundle which we would be discussing. So starting with something which we said is most important and most life-saving will be the 6 stages of hand washing. There are different mnemonics you can go for it. You can say Suman K, which says Seedha, Ulta, Mutti, uh, Angutha, nails or nakhun, and kalai. So Suman K is one of the traditionally used mnemonic which we use when we are talking about the 6 stage of hand washing. So just going by it, palm and palm, which is the front hands, and then the back of the hands where we interlock and do it both the sides. Then we see the interdigital spaces, the fingertips, the thumbs, the nails, and the wrists. So each step is very, very important, and this very small step can save many, many lives. Very simple studies have shown a healthcare worker touches approximately 1,000 surfaces per shift. So our job doesn't end when we enter this place and do a hand washing. It has to be done before every patient contact, before every aseptic precaution, after every body fluid exposure, after every patient contact, and after contact with any patient surrounding. So it has to be done repeatedly and has to be reminded and reinforced amongst yourself and amongst your colleagues, because that is what is going to save lives. There have been so many studies over and over again which have proved same. And what is the best way of doing it? The direct observation has been the gold standard. Reminding yourself, reminding your friend, reminding other people around, and helping each other build this practice is one of the best way. Bigger centers have come out with MediHand traces where they detect alcohol vapors, they detect radio frequency identification. I've known of hospitals who use auditory sounds to find out when the water was used and how well it was used. There are electronic monitoring systems, there are video monitoring systems. There have been various ways to increase the surveillance of hand hygiene, but what we can do today is to increase and spread the word and increase our own compliance to hand hygiene at every step. Despite all these measures, the compliance in most studies after the observation phase drops down to 30 to 40%. That is why it is a forever thing. That's why I say I don't teach anything new today. What I want to reinforce is to save lives, and that can be done by hand hygiene, by ourselves and helping our colleagues. And what to do, whether we do an alcohol-based hand rub or an hand wash. We can do either of that. Hand rub is equally good in most circumstances. However, if it is soiled with any biological fluid, if it is visibly dirty, or if we are thinking of C. diff, that's where soap and water is necessary. So a C. diff infection, visibly soiled infection, or visibly dirty looking hands is where soap and water is very, very important. And also when we do soap and water, it is important to dry the hands, wipe it with a single towel, and then let it dry before we make our next encounter. So Doctors hand wash somewhere around 40 to 60% in most studies. The statistics may vary. Nurses' adherence has been higher than doctor. And more often than not, when we think our patient doesn't know and doesn't think, studies have shown patient notice poor hand hygiene more than even physicians can think. So just give it a thought every time you go near a patient and you enter a hospital, and that's possibly going to save many, many lives, even though it might not look important at that time. Now, what is care bundles, which is the second part of my topic? It is a collection of interventions which is evidence-based. So Dr. Peter Provençot first started with it. It is a bundle approach where the goal is to save lives, and it is officially introduced by Institute of Healthcare Improvement, where we implement all the steps together. So if you reach a bundle, that means you have taken every step in that bundle properly, and that is when it is considered executed. So it is all or none. It improves patient recovery. If you do it in patchy ways, it's considered to be incomplete care bundle. So for a better outcome, the magnitude of improvement increases many-fold if the care bundle is taken. What is a care bundle? It is a group of steps we take together to prevent a particular kind of infection. Like Dr. Amit spoke about, central line bundles. So how we can take the catheter-related bundle infection and save infections from central lines. Ventilator-associated bundle is called the WAP bundle. So we have the WAP bundles, SSI, soft tissue infection bundles, UTI bundles, catheter-associated bundles, and central line-associated bundles, which we most commonly talk about. All the elements of the bundles must be executed at the same time to reduce daily hospital stay, mortality, and ICU complications. So we have the ventilator associated bundles, central venous catheter, peripheral venous catheter, urinary catheter, and SSTI bundles. Most of it has already been discussed by Dr. Amit in so much details and very clearly that I would be skipping most part of it. So I would focus on the MDRO containment bundle, which is how to prevent the serious bug infections, mostly in ICU, how to prevent the multi-drug resistant infections. So what is the core bundle? It looks, everything in this would sound very obvious, but doing it together is what matters. We need to identify it early. So what helps us to identify it early? Any recent history of hospitalization, ask your patients about recent history of antibiotic exposure, if they have been transferred from a long care facility or have had repeated infections in recent past, any previous history of multi-drug resistant organism. So it's a very, very important part of our history taking to identify our patients who have a high risk for an MDR infection. Then the second and the most important step, which I've been saying over and over again, is immediate transmission control. What we can do to save life. Hand hygiene, contact precautions, have sterilized equipments, dedicated equipments, and place the patient as and according to the guidelines. The cohort placement and the single room placement guidelines may vary from hospital to hospital setup depending upon the availability of beds, depending upon the patient load. So that has to be a hospital policy and cannot always be given a single room to every MDRO infection. However, wherever possible, an appropriate cohorting should be done. The third thing is device minimization. If patient needs ventilator, central line, urinary catheter, we will have to give them. But what is important is to review every day that whether we can remove it or not. A review or a checklist of this guideline to check if the device can be removed is a very, very important part of our daily ICU. So besides taking the initial history, we take every step to prevent the immediate transmission control, and then we think about our devices. Whether the patient needs that device or whether we can give him a break from the device. The next important part of this bundle is antimicrobial stewardship, which in itself is a big topic, but what we need to remember is to obtain cultures before escalation and whenever possible, and to review our antibiotics periodically, and to stop and de-escalate wherever appropriate. If we have an MSSA, as Dr. Amit said, we need to de-escalate from vancomycin to cefazolin or flucloxacillin or whichever is the appropriate antibiotic. A higher antibiotic does not always mean better outcomes. antibiotics should be given in appropriate setting and should be de-escalated as soon as
ಬೇಬಿ ಮಾತ್ರ
possible.
ಇದೆಯಾ ಬಟ್ ಇದು ಊಟ
And then is
ಡೈಜೆಸ್ಟ್
the most
ಆಗಲ್ಲ ಅಂತ
important part is audit
ಅದು
and
ಕಾರಣ ಇದೆ
feedback.
ಅದು
To continuously
ಇದು
be a
ಮಾತ್ರ ಅಲ್ಲ
dynamic process.
ತಿಂತಾರಂತೆ
None of us is
ಪಾಯ್ಸನ್
perfect.
ಆಗುತ್ತಂತ
Nobody can
ಅದೆಲ್ಲ
guarantee
use ಆಗುತ್ತೆ.
every step at every single life, every single encounter in their life. But what is
ಇದು
important is to be
ನಿಮ್ದು
aware of
food
that
poison ಇಲ್ಲ.
and trying to
Food
improve
digest
our
ಆಗಿಲ್ಲ.
practices every single day. Track our compliance, to think about new ICU MDRO acquisitions, take appropriate steps in our ICU, daily review of device minimization,
ಬೆಳಿಗ್ಗೆ
to daily
ಮಧ್ಯಾಹ್ನ
count
ರಾತ್ರಿ,
the antibiotic
ಬೆಳಿಗ್ಗೆ ಮಧ್ಯಾಹ್ನ
days
ರಾತ್ರಿ, ಎರಡು
and
ಊಟ ಆಮೇಲೆ
decide if
ಬೆಳಿಗ್ಗೆ
it is
ರಾತ್ರಿ ಊಟ
required
ಆಮೇಲೆ.
any longer, and discuss
ಎರಡು ಮೂರು
about
ದಿವಸ
antibiotic
ತಗೊಳ್ಳಿ.
stewardship every day.
ಅಲ್ಲ ಕಮ್ಮಿ
So, audit and feedback to track compliance, to look for new infections, to count the antibiotics therapy day. This is a basic checklist which we should have in our ICUs. Can an antibiotic be stopped, narrowed, or switched? Can any device be removed today? Are hand hygiene and contact precautions being followed? Is the patient appropriately placed wherever possible? Have culture results, antibiogram trends, and microbiology results being reviewed? Unfortunately, there have been cases where a microbiology culture is positive, but just because of a busy resident, we never got a chance to see because of a busy setting, we did not review it and missed the opportunity to de-escalate the antibiotic. And that might look like a very trivial mistake, but these small things go a big way in having the patient develop antimicrobial resistance or going back to a sensitive antibiotic and getting better outcomes. So, who should trigger MDRO infections? When should we know that the colonization is important? MRSA, VRE, CRE, CRAB, and ESBLs. We have already discussed the gram-negative infections. So these are the infections where we need to decide about whether we need to do decolonization and whether we need to do cohorting based on our hospital practices. We need to be aware about high-risk clinical context, prolonged ICU stay, any invasive device if patient has, is he coming from any another ICU which has a specific MDRO organism which is common in that ICU, recent surgery, dialysis, or immunosuppression, antibiotic risk markers like recent carbapenem use or some antibiotic use which has been done, and obviously it has to be tailored based on the local policy of screening cultures. In an immunocompromised transplant setting, we might be doing perianal screening for CRE and VRE in high-risk patients, while that might not be required in a high setup where the patients are more immunocompetent.
ಒಂದೆರಡು ಟೈಮ್
So coming
ಇದು
over
ಮೂರು
to
ಟೈಮ್
each infection and quickly
ಇಲ್ಲ,
just
ಅದು
telling the important
ಒಂದು ಎರಡು
point,
ಟೈಮ್
MRSA, which
ಇದು
is the
ಮೂರು ಟೈಮ್
gram-positive infection,
ಗೆಸ್ಟಿಗೆ ಮಾತ್ರ ಎರಡು
methicillin-resistant
ಟೈಮ್
staph aureus, how to protect it, hand hygiene, contact precautions, checking our device, and there are some chlorhexidine protocols for local decolonization, which needs to depending upon the hospital and the place policies. There have been multiple studies showing evidence in favor of chlorhexidine nasal decontamination, but there have been mixed studies based on different results. So that needs to be individualized based on patient and the policy. Then is the catheter related, then is the CRE and the ESBL infection. The precautions again remains very similar, strict contact precautions, stewardship, and minimum urinary and central devices, because those are the most common causes of ESBL and CRE infections. When we come to Acinetobacter, we have to take more importance to aggressive environmental cleaning and to especially decontaminate shared equipments. So in our hospitals, we have seen the ultrasound probes being the site of transferring stenotrophomonas. So the kind of thing which goes from one person to another, if we do not have a if we do not have an individual thermometer, the probes of different devices, those are the ones which needs specific decontamination. And if there's any cluster, to identify it fast and to give closer attention and then to treat it. MDR Pseudomonas is another very important organism, especially from water and environmental reservoirs. My hospital in the previous setting had a big outbreak for Legionella, and that's where the water reservoir was found to be infected. So to be also be careful about, besides the immediate environment, about the pipelines, about the water supplies, about the clothing or the beddings or the linens which come. So all these things need to be talked about, and it has to be a combination of everyone to try and identify a source if there's a cluster outbreak. And coming over to the personal protective equipments which we need to don and doff when we enter, we start with the shoe cover, cap, then go for the hand washing, gown, mask, goggles and gloves. And we remove it in the opposite order. That is, we first remove the gloves, then the face shield, the gown, the mask, the cap, the shoe cover, and again do the hand washing to go over and over the process again. Respiratory hygiene and cough etiquettes remain important when we are talking about the respiratory infections. There are positive pressure rooms and negative pressure rooms. Uh, One of the common exam question in entrance test is the number of air exchanges per hour, which has been changing but is most commonly decided as more than 12 air changes per hour. A positive pressure room is a room which maintains a higher pressure and is where the immunocompromised patients or OTs are usually kept, so that there is no infection which can enter in the room. Negative pressure rooms are the rooms where we trap and keep the potentially harmful particles to not enter the hospital and leave the space. That is like tuberculosis. So if we have the facility of pressure ventilation rooms, TB will be where the negative pressure ventilation would be there, and an immunocompromised patient would be kept in a positive pressure room. Uh, uh, Most of this is a part of a different topic, but very quickly just going over the other bundles. VAP, which is ventilator associated care bundle. There are different parts of this bundle which we need to take care. So if our patient is on ventilator, we need to elevate the head end by 30 to 45 degree. We should give a sedation break daily and assess every day if we can extubate the patient. Chlorhexidine was a part of the initial care bundle. However, because of the mixed evidence, it has been removed from several guidelines. Peptic ulcer disease prophylaxis and DVT prophylaxis if not contraindicated. So this is a VAP bundle. If just to improve the compliance of all these, making a checklist in ICU is supposed to be improving the compliance and the outcomes significantly in most clinical setups. So that is what I would encourage residents to make that habit so that we can work and improve the outcomes of our patients. I would skip the central venous catheter in interest of time and also because it has been discussed. Catheter care bundle, very briefly, don't put them in unless it is needed. Patient's request is not an indication for urinary catheter. You are doing more harm than good if it is just for the sake of convenience than for an actual indication. Look after the catheter with dressing, hand hygiene, daily checking if it is required or not. This is for catheter, urinary catheter. Catheter removal, aseptic precautions, regular assessment, and training every day if it is required or not. I'm not going into the details of the videos of the same. And so coming over to the take-home messages so that we can discuss your questions at the end. A strong commitment towards infection control is required. Regular training, regular feedback, daily dynamic review of our own practices improves lives. Clean hands can save lives. We haven't talked much about the syringe and the sharp precautions. I missed it in interest of time. But one needle, one syringe, one type, and a proper recapping is the small thing I would like to reinforce. And just at the end, a proper hand hygiene and the steps of hand hygiene can save many, many lives. I would end my talk with this.
Thank you, Dr. Parul, for nice talk. So now we are having some questions, and I would recite the questions, and then both of the speakers can reply. What clinical laboratory criteria do you use
Stop
to
sharing.
differentiate? Hello?
Dr. Parul, stop sharing these slides. Okay.
So, what clinical and laboratory criteria do you use to differentiate a true catheter-related bloodstream infection from contamination?
Yeah. very
when
good.
only 1 or 2 blood culture sets is positive.
Yeah.
So out of two, one is positive. How you differentiate?
Yeah, very good question. And again, these are the dilemmas which we face every day, because all our patients who come into the ICU come with some amount of antibiotic exposure outside, because of which getting really a patient who has central line blood culture and peripheral line blood culture positive is very, very rare. Again, clinical things I would consider first. If the patient has fever, hypotension, tachycardia, tachypnea, is in sepsis, I would err on the side of having infection rather than contamination. The organism which I find on blood culture, if I find Staph aureus, if I find Pseudomonas, if I find Candida, if I find Enterococcus, then I would err on the side that this is an infection rather than a contamination. I would also like to look at metastatic complications. So if the patient has an endocarditis like my patient had on 2D echo, or has spondylodiscitis, or has thrombophlebitis, then I would go more in favor of infection rather than contamination and treat the patient. And also, if one blood culture set is positive and we are going to remove the catheter anyway, then doing a catheter tip culture, and if the catheter tip culture also grows the same organism, I would be more on my to treat this patient for infection rather than contamination.
No, do you send nowadays catheter tip culture?
No, sir. No, we don't send.
We
But
don't send. So
yeah,
I
the
think
guidelines
now
were that
get this
it's
suppression
yeah,
of catheter tip,
correct.
because no longer people practice catheter tip
Yeah,
culture.
but the guidelines say you can still send. Not a problem.
So next question is, in a patient with suspected CLABSI, what is your approach to paired blood culture? Differential time to positivity versus quantitative culture ratio? And which do you find more practical in Indian ICUs?
For me, it is neither, because it's very rarely that both cultures will grow positive. But yes, differential time to positivity is more practical. Sometimes they also look at semi-quantitative cultures, and the central line culture as to peripheral line culture has to be 3:1 or sometimes 10:1. But I don't think so. We have that much time. The microbiologist or the intensivist has that much time in the ICU. So yes, both cultures being positive and the patient having symptoms and sometimes metastatic complications is enough for me to start treating the patient for infection.
Okay. When do you choose catheter salvage with antibiotic lock therapy versus immediate line removal in the patients with CRABSI?
Yeah,
Or which organism would you like to abandon salvage attempts altogether?
so I have already made it clear there
Yeah.
are three organisms: Staph aureus, Pseudomonas, and Candida, where immediate removal of catheter has to be done. We don't have any time for salvaging the catheter. But yes, there are certain organisms which are not that pathogenic, where the patient, if he has no other IV access, or is obese, or he has extensive burns, where you want to save the catheter, there you can look at antibiotic lock therapy, especially organisms like coagulase negative staph or say MSSA. We can try, but again, Staph aureus no, Pseudomonas no, Candida no, catheter has to be out.
We have already discussed the empiric antibiotic selection for suspected CLABSI, neutropenic versus one who not. I think Dr. Amit has already covered this.
So the only thing is that if you are neutropenic, then you have to consider giving empiric therapy for gram negative organisms as well, because and plus may consider Candida also if the other risk factors are present.
Next question is about the Candida causative organism and device related bloodstream infection that we have already discussed. So I would like to skip this. In a patient with persistent bacteremia despite catheter removal and appropriate antibiotic, what is your next diagnostic step to rule out endocarditis and septic thrombophlebitis?
Yes. So metastatic complications, number one, look at the heart, do a TEE, rule out an endocarditis, look at spondylodiscitis or osteomyelitis, ask for any prosthetic issue in his body, like a prosthetic valve or a AICD or an intracardiac device or a prosthetic joint. Also identify the organism. If it's Staph aureus or if it's Candida, we know that it takes time for becoming culture negative. So identify the organism, look at what dose you are giving, because if you are giving vancomycin, the dose of vancomycin is important. If you are giving daptomycin, the dose of daptomycin for culture negativity is important. Similarly with Candida, what antifungal you are giving, what dose are you giving, whether it is fungicidal is very, very important, and obviously metastatic complications you have to look into.
So what specific criteria distinguish CLABSI from the secondary bloodstream infection with another identified source, and why does this distinction matters for surveillance reporting?
For surveillance reporting, yes, but for ICUs, I don't think so. We need it.
Yeah, agreed. How do you manage a tunneled or long-term catheter if a patient with CRCCID when the line, we have already discussed, the line is essential. Yeah. What has been your experience with antimicrobial or antiseptic impregnated catheters in reducing CLABSI rates in high-risk ICU population?
I think Parul can answer that question.
Yeah.
That's a question. Studies have shown that they do cause lesser healthcare associated infections and they can be kept in the body for a longer time.
Which component of central line insertion bundle do you mostly commonly compromise in real world in ICU? I think any bundle, any component can be breached. It
Hand
depends
washing,
on the
hand washing, I think.
hand washing.
Very bad at hand washing.
How do you ensure maintenance bundle compliance, such as daily line necessity review? Just audit can be done, nothing else. There is no other method to ensure. It's a audit and checklist checking. What role chlorhexidine impregnated dressing play in your infection control protocol? Have you seen a measurable impact on CLABSI rates?
Dr. Parul.
Dr. Parul?
We scrub our hub with chlorhexidine, which has been an important part of the practice, but I do not have the statistics comparing before and after. So
No, they are asking the chlorhexidine impregnated dressing. So certain dressings are, yeah.
Yes,
Just louder.
in high-risk ICU.
Louder, please, louder.
So have you seen the measurable impact on CLABSI rates?
I do not have data, but yes, we do use it, and the practice has changed to using it. So I would say it's a measurable impact, but I would not comment on it because I do not have the data and statistics to compare pre and post. So.
How do you approach surveillance and benchmarking of device-associated infection rates in ICU, and what denominator? This is a common question, so I don't think so is an important part. What has been most of the corporate hospital, they are maintaining this data. So what has been the most effective intervention in your institution for reducing catheter-associated urinary tract infection?
Dr. Parul.
Dr. Parul, can you?
A checklist of whether the
All the questions are all directed towards you.
Yeah, most of the questions are now directed towards Dr. Parul.
Yeah, so I think for any infection control, the most important part is to review whether you need the catheter or not, and daily review of the need of catheter. And unnecessary catheters are the most common cause, and if we can identify and increase the duration of days, if we can reduce the device days, that's the most important intervention, I would say, in terms of prevention.
Most common breach in hand hygiene compliance, everybody knows it's an essential part. It's very difficult to pinpoint which aspect is there. How do you decide when to place a patient in multi-drug resistant organism with a MDRO in a contact precaution versus more stringent isolation measures? I'm not sure
I think this depends so much on the hospital settings and the availability of rooms.
Resources, yeah.
I mean, I worked in hospitals where we did not have the opportunity to even cohort to one MDRO and one TB patient, and compromised patient, and have shared the beds, unfortunately, and to a system now where cohorting enters at the ED, and there's a separate whole building for an MDRO organism. So it depends on the resources and whatever best we can do to cohort it.
Next question is also related to this. He says if you have isolation rooms are limited, so patient infected with carbapenem resistant organism.
Yeah, cohorting is almost same. It depends on the available resource. Balance the risk of catheter-related infection against the clinical need of multiple vascular access device. We have to make a balance. It's very difficult to pinpoint what is the balance, how you can make the balance once. Every day one has to check whether this vascular access device is needed or not. If it is not needed, we should take out. That has already been discussed multiple times. What is your approach to decolonization studies, such as chlorhexidine bathing and nasal mupirocin in patients with high risk for device-related infection?
So we have done chlorhexidine bathing and mupirocin, especially in immunocompromised patient or patient with recurrent MRSA infections. The guidelines and mixed evidence is there, which is a whole discussion topic. So I would, as of now, leave it on individualized patient when it is a repeated infection or an immunocompromised patient.
Yeah,
And
but
again, going back to cohorting, there are centers where we do, in all transplant centers, they prefer to do it, especially if the cohorting, even after cohorting in isolation, the risk is it's a recurrent infection. That's where it is uh, considered as a high indication
yeah,
for doing
and
it.
I would suggest that all the pre-operative patients where we are doing a high-risk surgeries, chlorhexidine bathing has got definite role because it's a well documented, it benefits them. As far as the nasal mupirocin is concerned, in India, the gram-positive infection is not that high. So it depends on the institutional practice, which some institutions still do, some institution doesn't do. So many institutions take the nasal swab of the patient, look for any gram-positive, and then go for mupirocin. Some institution doesn't do that practice. Last question we have already discussed about the infections in immunocompromised host, like a transplant patients or versus general population. We have already discussed in one or first or second question. So with this, I don't
Can I
think there are
ask
any.
Dr. Kodan, what is the disadvantage of chlorhexidine bathing? Can it increase the resistant organism growing on that patient?
I'm not sure about increasing the resistance, but
Because
two
certain
or three
institutes
of the
don't do
common
it.
things which we have seen is an allergy or a skin irritant, or some people who do not tolerate it. And the second is less benefit even after multiple chlorhexidine washes. It doesn't really improve, and the false sense of safety. So the evidence in favor of it is not very strong, but it is. I mean, it must be given in specific setup, is what I know best. And I
Like
have seen
the
patients developing
preoperative.
allergy and nasal bleeding after mupirocin ointment. So I'm not sure about the resistance part of it, but it definitely has the skin complications which can.
In the place where you work, what is the compliance of hand hygiene? I mean, do they have
So like
people
every
there?
other place, whenever it's under surveillance, the compliance increases, and when the surveillance goes down, the compliance falls
I
down.
think it is all over the
And
world
I
the
think
same
that's
thing.
all over the world and every place. So I have been to one of the place for observership in Switzerland, where kind of monitor, they have like 10 different monitors, and every patient, I mean every doctor who misses it has a whole session of talking and discussion after that, and even in that setup the compliance rate is 50 to 60%. So um,
No,
so
but I think whosoever is listening, let's do this because this is one. We will write down the best antibiotics. The costs are so high, and patient, doesn't want. Cannot afford many a times. And simple thing can really save a lot of things. And I think we need to do. Unless we do, the sisters won't do. And if the sister won't do, the housekeeping staff will not. So I think you have to lead by example. I
yeah,
at least
and
do.
it definitely saves lives. I mean, there is absolute data. I mean, when I was the names, we had an ICU protocol, and once we stopped the project, the rate of infections actually doubled. And I mean, it was so glaring, and yet we forget something as small as this. I mean, as important and as basic as this, which is.
You know what I have done in my ICU? I tell every sister to give me as soon as I reach. So they are ready with that. So at least I do, and many the students and everybody, there is increase because of that. They think it is important, and they also wash. But I think we need to keep on working till we have 70-80% compliance. Uh, Deepak, you wanted to say?
No, everything is already being said. I think it's time to wind up the session.
Okay. So with this, I would like to thank Dr. Deepak for moderating this session, Dr. Amit and Dr. Parul for taking wonderful lectures from the heart, and of course Dr. Akanksha, who's been working tirelessly for last 15, 16 weeks to prepare a lecture, which is different from what has been taught, and it is not the same what you hear in the last. And I'd also like to thank ISCCM for endorsing this event and Hexicon for conducting it, and the Zymes like BioLize. Zymes Life Sciences for supporting this event, and also the people who are always there in large numbers to attend it, which is keeping us more active, and we will continue to do this. So we are now reaching towards the end, not the end, so 17th module number 17, which is on antibiotic stewardship next time. And then we go on to the lung conditions one by one. So thank you very much. Have a good night. And Dr. Parul, I hope you have some rest. She's just come from a long flight. Thank you very much.
Thank you so much. Thank you.
Thank you for joining, sir. Thank you.